length. And I think that Dr. Zaina, she's invited to share her presentation. I'm right, Dr. Zaina. Yeah, yes, my dear.
Thank you. So again, this was such a phenomenal meeting, and I'm so happy and excited to have been asked to present here. I'll be talking about IOL calculations in extreme axial lengths. I definitely want to thank my group at Baylor, who's, Doug Koch, Lee Wang, who's done a lot, Mitch Weicker, who's done a lot of the work with IOL calculations. These are my financial disclosures. As we know, patient expectations have skyrocketed. They want the perfect surgery, they want excellent refractive outcomes, and they want minimal costs. There's a recent study that showed the most common cause of dissatisfaction after multifocal IOL is ametropia and astigmatism. So no matter how much we talk about all of these other things, it's important accuracy of IOL calculations. So precision of preoperative data, basically garbage in, garbage out. So if you have an error in your axial length measurement, about a 1 millimeter error, you can get a 2.5 diopter error, which could be translates to about 1.66 refractive error. Keratometry, it's a little bit less, but still significant. And of course, effective lens position. More recently, so in the past, it used to be axial length was the problem, but with excellent biometries and optical biometry now, it's really effective lens position, cornea, measurement of true corneal power, and refraction that could be the results of error. Modern formulas perform pretty well on average, but it's really the extremes in which patients don't do as well. And really the big take-home message from my talk is most IOL calculation formulas will do well on average with most eyes. It's those again, extremes that people have some issues with. So in short eyes, typically we overestimate the required IOL power and can result in a myopic error. On the other hand, long eyes, you get a hyperopic error. And just to get a big picture, so patients less than 22 millimeters axial length in America, it's about 4 to 7% of the population, versus long eyes is more common, about 8 to 16%. One thing I want to say too, people have been talking about third generation formulas, fourth generation formulas, and newer generation formulas. It's important to note that that's the old classification. In a recent editorial by Doug Koch, he really wanted to hound this concept of thinking of IOL calculations using functional classification. So geometric optics, and it's based on the number of variables that are used, like axial length and cornea and the Holiday 1 Hoffer Q SRK2, and adding variables like anterior chamber depth, and so forth. Ray tracing is the Olsen, is one great example. Artificial intelligence, we utilize the Hill RBF, which we like. And then there's the new combination formulas such as the lattice formula. So let's talk about long eyes, as we talked about, where patients used to get hyperopic errors until Lee Wang and Doug Koch from my group again did a great study to show that if you optimize the axial length, so and it's important to note, it's these 4 specific formulas: Holiday 1, SRK, Hagus, and Hoffer Q. You take the axial length that you get, you multiply it you put it into this equation, and you get a shorter axial length to avoid the hyperopic error.
Zaina,
so there was a
Zaina,
study that was done.
If you don't mind, Zaina, this matter is very important. Yes. So I just need to interrupt you because this study that Thomas Conan, one of the partner here in it has a certain formula, and this formula, because you passed on it because the others maybe they didn't know this formula. Our audience, there is a formula, and Zaina, she's putting the classical, the reading axial length plus this formula, then she will get these numbers. Yes, my dear, continue.
Exactly. So you take your axial length that you get from the actual, optical biometer right here, and then you multiply it by, for example, 0.8289 for Holiday 1, and you add a 4.2663, and that's your adjusted axial length. Yes, exactly. And again, I wanted to note, it's really important, but newer formulas like the Barrett already have that inputted into their formula. So you don't need to adjust the axial length. Otherwise, yes, you're going to double it and you end up with a myopic error. So these are the 4 formulas specifically. In this study, intraocular lens power calculations, and I forgot Dr. Cohen was with you actually, so thanks for reminding me. So that's that was a really great landmark study.
That's right.
IOL power calculation for patients with axial length greater than 26 millimeters compared all the different formulas: Holiday 1 doing adjusted or not adjusted, SRK, Hoffer Q, Haggis, Barrett, and Holiday 2. And really the key point is that IOL powers less than 6 diopters. The best results occurred with the Holiday 1 with the Koch-Wang adjustment, a Haggis with the Wang-Koch adjustment. And then, like I said, the Barrett, you don't have to do the adjustment. It already has it included in there. And those 3 were excellent. And so, again, this is more important the longer the axial length. So you can start using it after 26 millimeters, but it makes much more of a difference in longer axial lengths. And in general, if you think of, myopic patients or long axial length, the IOL power is actually pretty small. So the effect is much less versus short eyes. As we talked about, you get a myopic error because you overestimate IOL power. And part of it, we think maybe it's the ELP prediction. Are we underestimating ACD with a decreasing axial length? The errors here are magnified. I really think, other than post-refractive or keratoconus, short eyes people kind of forget about, but those are the ones that you're more likely to get errors, and they're magnified because you're using higher IOL powers, 30 diopters, 34 diopters, and the shallow anterior depth, anterior chamber depth. So it's even more anterior, and you get more of a myopic error.
Yes.
And if you notice, if you are off by 0.25 millimeters effective lens position, again, to explain this point, you'd get a 0.1 diopter error in a 30 millimeter eye. Not a big deal, right? Versus a 0.55 diopter error in a 20 millimeter eye. So we thought about our formulas that use pre-op anterior chamber depth and or lens thickness more accurate. So again, our group looked at the Haggis, Olsen, Barrett, and Holiday 2. And before I get to that study, this is the literature that's out there. There's really variability in short eyes and which formulas are better. There's a study that showed that the Haggis, a couple of studies, some showed the Holiday 1, some showed the Olsen, and then more newer studies show the Barrett Universal and Hill RBF. So our group retrospectively looked at 86 eyes for axial lengths less than 22 millimeters and looked at 7 formulas, the Barrett, Haggis, Hill RBF, and then the remainder as we saw. And we really didn't see any significant differences among the 7 formulas if you optimize your formula. So what's our approach to short eyes? We've been pretty good about optimizing our Holiday 1 and Holiday 2. So we're very comfortable with that. We're also really liking the Hill RBF and the Barrett Universal, which are excellent formulas. And sometimes, if things don't necessarily agree, that's when we look at the Olsen to maybe just kind of nudge it a little bit closer to the Olsen. And in general, if you're worried about IOL calculations, typically utilize doing the surgery on the non-dominant eye and factor refractive RPE of the first eye into your IOL choice. One point I wanted to add is, I truly believe it's really the effective lens position that's the error, the part that we really can't calculate. And so errors in the prediction of the post-op ACD, it might account for much more, like 20 to 40% of the total refractive prediction error, even if the IOL calculation formula is perfect. And the difference, in accuracy between formulas might be a result of the difference in how they estimate their pseudophakic anterior chamber depth. So we wanted to look at patients that had normal axial lengths, but variable anterior chamber depth. And we retrospectively looked at 270 eyes. It's also another point that we forget about. It's not just the axial length, but looking at that variability. So we define anterior chamber depth less than 3 millimeters and between 3 and 3.5, greater than 3.5 millimeters. And then
your sound is interrupted. Sorry. So few things we couldn't hear it. So if you could just repeat.
So basically, in addition to just looking at axial length and just thinking about short versus long eye, it's important that sometimes in normal eyes, you have variability in anterior chamber depth. And that's why sometimes you might get some post-op surprises. And so we looked at 270 eyes with normal axial lengths between 22 to 25, and then divided them into 3 groups: less than 3 anterior chamber depth millimeters, normal between 3 and 3.5, and greater than 3.5, and then compared the 7 formulas here. And there were interesting results. So the MPE was not significantly different from 0 in patients in the Barrett, the Holiday 2, the Haggis, and the Olsen, if it's less than 3 millimeters or greater than 3.5, versus all formulas did well, and there was no significant difference in the average anterior depth. And again, these are those formulas, newer formulas that show up in the extremes of eyes in which patients do better. And just because of time, this is just a really point that anterior chamber depth was an important variable in the accuracy of IOL calculation formulas, and even in patients with normal axial links, but if they had shallow or very deep anterior chamber depth, in which there was an improvement if you utilize for example, the Barrett formula or the Holiday 2. So multiple variable Vergens formulas, again, like the Barrett or the Haggis and the Holiday 2 and the Olsen, did better than formulas that did not take into account anterior chamber depth. And so in conclusion, patient expectations are very high, especially for premium lenses. It's important to get good quality measurements, which we didn't really talk about here. But in general, you can use any formula for average eyes. It's those patients with extreme anterior chamber depth or axial links that can have potential errors. And we're getting better and better with our newer formulas. And it's important to take preoperative anterior chamber values into consideration when picking an IOL. The way I look at it, normal eyes, we look at our Barrett, Hill, RBF, and Holiday 1. That's really optimized. For short eyes, again, look at the Olsen if there's something we're not worried about. And then the Barrett and the Holiday 1 adjusted for the long eyes. So thank you again.
Great, thanks, Zaina. It was a comprehensive talk about the biometry. And I thought that when I was talking about the ACD below 3 and above 3.5, I was the only one that someone will laugh on my side what you are doing. No, it's the real. The only issue is that I need just to, because I have 2 minutes to interfere with you about the best and the better formula below 2.5. And I found with a comparative study that we are running between Barrett Universal and Hoover Q, well, the plus minus 0.25, 0.5, let us say, it's with a favor of Hoover Q. Now, I do agree with the 2.5 ACD, because the 2.5 ACD, it will be considered by Barrett Universal in a certain way, but it will not be the actual post-op. And from this explanation, the Barrett will not be very accurate in dealing with the 0.5. But Hoover Q, which considering mathematically is estimating the effective lens position, it gives a better result with ACD below 2.5, and that's a comparative study running, and we will see how we can end up with this study. So great, thanks again for you, and we will go back to the schedule. Yes, Zaina. Unfortunately, your net is not good. I think that the net is being tired. So we will go to, Zaina, we are not hearing you. So we will go to our dearest friend, Dr. Ahmed Assaf. Dr. Ahmed, you are mute. Yes. So okay. Ahmed Assaf, he will tell us about another challenge, a biometry in keratoconic eye. So Ahmed, you are most welcome.
Thank you very much, Dr. Safwan, for the invitation to share in this symposium or webinar. And I'm charged here to talk to you about the biometry in keratoconic eyes. To cut it short, just start the screenplay, okay. To cut it short, I'm going to answer 5 questions. First question is why IOL power calculation is inaccurate in keratoconic eyes. The second question, which biometric formula to be used. Third one, which K readings should we consider in keratoconus? What type of IOL should we consider in cases of keratoconic conus? And finally, whether we can implant toric lenses or not toric lenses in keratoconic eyes. Regarding the first question, we have main reasons why the IOL power calculation is inaccurate because of the disturbed ratio between the anterior and posterior corneal curvature. And this the normal corneal curvature results in a normal refractive index of 1.3375, which cannot be applied in cases of keratoconus and of course in cases after laser vision correction. The second cause of inaccuracy is in the inaccurate K readings on the corneal surface because of the asymmetry in the corneal curvature. The third is the inaccuracy in prediction of the effective lens position because of the steep cornea causes hyper deep anterior chamber, and the effective lens position cannot be predicted accurately like the virgin eyes. And the fourth, the disturbed tear film on the corneal surface limit the predictability and the repeatability of the K reading measurements, as we have just said in ocular surface disease. And finally, the visual axis of the eyes of keratoconus may not pass through the steepest portion of the cornea. So because of these reasons, the IOL power calculation is challenging in cases of keratoconus. This is an example you can see here, just in the right eye in the flat meridian. You can see above the corneal vertex, the K readings in the central part, just above the corneal vertex is 44.9 diopters, while just below the corneal vertex is 57.7 diopters. So huge variation in the K readings, even in the small optic zone. So regarding the second question, which biometric formula shall we use? Surprisingly, the SRKT has the lowest prediction error compared to the other formulas like the Barrett, Haig's, Holiday 1, Hofer Q formulas. The SRKT formula is not affected by the anterior chamber depth, and it underestimates the corneal power, which leads to some sort of myopic shift. And we can use this for the to compensate for the hyperopic shift that always occur with keratoconus, especially with other formulas. Other biometric formulas are proved to be less accurate compared to the SRKT formula. However, we still have to target low amount of myopia after the surgery. For example, this depends on the K reading. For mild cases of keratoconus, we shall target around 1 diopter of myopia. For moderate cases, we shall target around 2 diopters of myopia. And for advanced cases of myopia, like K readings of 52 or more, we shall target 3 diopters of myopia or more. And this is to compensate for the potential hyperopic shift and the future, maybe future cross-linking flattening effect, which is unlikely in this age group of patients, but just in case if the patient received future corneal cross-linking. Remember that the uncorrected visual acuity in these patients is pretty well, because even in the presence of low amount of myopia, because this is a multifocal cornea and we have some neural adaptation. Regards the third question, which K reading shall we consider? Keratometers use the refractive index like the virgin cornea is 1.3375, which is not applicable, as we mentioned, in cases of keratoconus. And the same applies with the corneal topography, although it measures more points on the central corneal surface, but still uses the same refractive index like the keratometers. Probably the pentacam, which uses the total corneal power, we can get the total corneal power in the Scheimpflug camera, which incorporate the posterior corneal surface in the calculation of the effective total corneal power. As you can see, the difference between the axial or the anterior surface of the cornea and the total corneal power, you can see here the difference in the regard the amount of the mean K reading as well as the astigmatism. However, we cannot apply these measurements directly to the biometric formula because the biometric formula is built based on the refractive index of 1.3375. So which K reading still we can consider? We can consider the measured K reading from the anterior corneal surface in mild cases and moderate cases of keratoconus, but still we have to target low amount of myopia, around 2 to 3 diopters. In severe cases, it has been proved that the measured K reading is less predictable and less less predictable compared if we use the standard K readings of 43.225 diopters after targeting low amount of myopia or moderate amount of myopia. So in severe cases, it's better to use not to use the standard K, but rather to use this. It's better to use the standard K readings of 43.25 and target moderate amount of myopia is to get the best results. Of course, if we have the option of holiday report, equivalent K reading 65, which used the 65% of the average weighted total K in the center at 4.5 millimeter, it provides the best or the more accurate results compared to the other formulas. Now, can you hear me?
Yeah, we are hearing you.
Okay.
And your slide with us.
Okay, now regards the fourth question, which type of the IOL? The safest option is to use the IOL with zero spherical abrasion. The keratoconic patients have corneas have massive amount of corneal abrasions and difficult to predict the interaction between the IOL and the corneal abrasions. And don't forget that these patients have eccentric fixations, so we need to use an IOL which is less sensitive to decentration. So it's best to use the IOL with zero spherical abrasion. My second option is to use a spherical IOL, but it's better to avoid aspheric IOLs with negative spherical abrasion because it may interact with adverse effect with the corneal higher order aberrations. Now, final questions, whether to use the toric IOL or not. We can use the toric IOL if there is improvement in the visual acuity with refraction. That means that the cornea suffers less amount of higher order aberrations, and the corneal cylinder is 2 or diopters or more, and there is consistent measurements between the topography, pentacam, IOL, and sometimes refraction if available. Or we can get, or a bow tie can be elicited in the central zone of the cornea, the pupillary zone, as you can see in this example. And of course, if the patient is not willing to wear or put on RGB lenses after the cataract surgery, it's not recommended to use toric IOL if the patient is so happy with the RGB lenses and willing to put the RGB lenses after the cataract surgery, because this will unmask the cylindrical power on the toric IOL. Which axis should we consider in cases of toric IOLs? We should consider the axis of astigmatism in the central pupillary zone, not the same K. You can see there is a great difference between the same K on the pentacam, and we can manually here see that the axis of astigmatism in the central pupillary zone is quite different. So we have to take this into consideration and use the K, the axis of the astigmatism in the central pupillary zone, not from the sim K on the topography. To summarize, why IOL power calculation is inaccurate because of the asymmetric K readings, disturbed ratio between the anterior and posterior corneal surfaces, deep anterior chamber and tear film irregularities. Which biometric formula shall we use? It's best to use the SRKT formula and target low myopia according to the K readings, mild, moderate, or severe keratoconus. Which K reading shall we consider? Effective equivalent corneal power or holiday report on the pentacam is the best results, or we can use the measured K in mild and moderate keratoconus. If cases of severe keratoconus or advanced keratoconus, we shall use the standard K and target moderate amount of post-operative myopia. Of course, the type of IOL, spherical or aspheric IOL with zero spherical abrasion is the best choice. Stay away as much as you can from the aspheric lens with negative spherical abrasion. We can use toric IOL if we can elicit a bow tie in the central pupillary zone. And of course, the axis should be based on the pupillary zone or the optic zone, not on the sync K. Thank you very much for your attention.
Great, thanks, Dr. Ahmed, for this comprehensive and nice presentation, well prepared. And I think that we need to ask our panel, because we have still few minutes to tackle myself. Dr. Nancy, Dr. Zaina, is anyone with us?
Yes.
Yes, Dr. Zaina. Do you have any question for Dr. Ahmed to embarrass him? I think that no one embarrassing Dr. Ahmed till now.
No, huh? It's very hard to embarrass him. He's
embarrass Ahmed. Yeah, it's very hard. No way.
No. You are very generous by your words.
No. There is no generosity in this way. So I think that the modification of the K, you were absolutely right. And the main important issues that we are facing with these cases of keratoconus is the hyperopic shift, depending on the K that we are dealing with. And even if we modified, as you said, even if we are modified, we need to adjust the target. We are not targeting zero here. There is no zero. And in spite of all what we are doing, we need to inform the patient that there is no zero in these cases, and the shift, whether it's myopia or hyperopic, and mostly hyperopic, because sometimes we are modifying, and we end up with a myopia, Dr. Ahmed. So
yes,
we need to inform him that there is no ideal formula or ideal methods to have an ideal vision post. Now the question is that you mentioned that toricity in those that they have K reading reasonable below 50, let us say. Do
yes.
you have any history of multifocal toric in those cases?
For my patients, I would never implant multifocal toric in these patients. I cannot guarantee the quality of vision, even if I can guarantee the biometry, which is of course impossible as well. I cannot guarantee the quality of vision because the cornea is totally missed by higher order aberrations, and this will interact definitely with the higher order aberrations on the lenticular level. So stay away from these lenses, of course.
Zaina,
and the
do
other,
you have any experience with the EDOF or trifocality?
No, I'm very, very conservative. I agree with Dr. Ahmed Assaf.
Exactly.
You're already getting a good depth of focus. These patients, they already have a multifocal cornea. So I would never do that on these patients.
Very good. So,
and then the other thing.
Yes, my dear.
We did a Galilei study, one of my partners, Dr. Kandawal, and looked at kind of the posterior cornea and keratoconus patients. And just to kind of to support what Dr. Assaf mentioned, is patients with greater than minus 6.5 diopters of the posterior corneal power were the patients that had much more outliers in terms of, because increasing posterior corneal astigmatism, you're going to get more of a myopic result, hyperopic result. And so it's very interesting. Those are the ones that are the outliers, and it's exactly what you said, because we're not capturing it.
Exactly. The vertical comma that they have a higher comma usually in the lower part. So it's enough for them to read, and they are happy with it. So we don't need to change their life to unhappy. I think that it's time to share my presentation, and we will go through and look at what we have here. That's a biometry post-refractive surgery. And I think that all of us agree that we have an increased number of cataract requirement after refractive procedure. Now, cataract surgery, post-refractive procedure is noted for increased number of biometry arising error. I'm sorry for that. Just I will exit to hide here. So that error is coming from the radius error, curvature measurement, keratometric index error, keratometric index, and intraocular lens formula error, erroneous IOL position. So what's happened in source of error after myopia? That's the cornea in the up was normal, and what we did is that we ablate the surface. So we changed the contour of the cornea, and we made it thin, flat in the center, and the power is changed totally at the anterior field. If we are depending on the anterior reading or anterior K, 100% we will have a post-op hyperopic shift. And if we have a hyperopic treatment in reverse, we are treating the periphery and steepening the center, so we will end up with a myopic shift because we are increasing the power of the center. And because of the increasing of the power of the center, the ending with a myopic shift. Now, keratometry and topography devices measure anterior surface of central cornea. K in D is derived from R in millimeter radius measuring using an effective refractive index to falsely consider a single refractive lens representing anterior and posterior surface. This effective refractive index is considered valid as long as radii of anterior and posterior surface of the cornea are proportionate and resemble that of the model eye. So the RI is a standardized value, 1 refractive index. It's 1.3375 in most keratometry and the CVK devices. The radius of anterior surface is considerably increased and distance between both refractive surface is decreased. Therefore, calculating keratometric diopter from anterior radii of curvature is not accurate. Now, in the formula, estimation of effective lens position by the third or fourth generation formula is not correct when the postoperative corneal power value are used, because in this eye following myopic surgery, for example, if the flattened postoperative corneal power is used to calculate the effective lens power, the predicted effective lens power, because it's in the third generation, it's a predicted, it's mathematic, will be falsely shallow and result in underestimating of the IOL power, then hyperopic shift. 1 millimeter error in effective lens power correspond to 1.5 diopter change in the final refraction. Most of third generation theoretical formula, example SRKT, Holiday, use axial length and corneal power value to predict effective lens position. These formula assume the longer the axial length or steeper the K value, the deeper the anterior chamber. The shorter the axial length or flatter K value, the shallower the anterior chamber. This is the principle or the concept of the third generation. So from this point of view, we will end up with myopic treatment with hyperopic shift and hyperopic treatment with the myopic shift. Now, source of the error in SRKT is the K. In Holiday 1 is the K. Holiday 2, K. Hoover Q, K. Haggis, yes, we can use it because they are not using the K. Now, Barrett True K formula, Shammas PL formula, Maloney and Koch Maloney methods, wavefront aberrometry, ray trace, OCT based IOL calculation, and Haggis L formula. Each of them, they create its own equation to modify the K reading in a way that it will correct the result of post-operative, whether it's myopic or hyperopic. Barrett True K formula, unfortunately, till now they didn't publish or show what's the equation that they are using to modify the K, but it's free, present in ASCARS and ASEAN organization to be used by any users. But there is no formula published till now. Other formula, each one having certain equation to use in a way that they correct the K reading, and that's the Haggis L formula, Shammas and Maloney and wavefront. Now, wavefront aberrometry, I do agree that in wavefront aberrometry they depend on, more recently, the use of intraoperative wavefront aberrometry has been described to further refine outcome result using the WaveTech intraoperative wavefront aberrometry, where compared with the several established formula in post-operative and post-refractive patient, the WaveTech reading were more accurate than predictive formula, most often predicting to within plus minus 0.5 diopter of emetropia. But what's the pros and cons here? The issues is that it's very expensive. We need a bank of lenses behind us to tell us which one, because it's an intraoperative. So practically, it's not a practical issue that we can follow. And ray trace, it's very promising in calculating the refracted ray at both, as Reina, she said, anterior and posterior surface. Avoid the use of the average fictitious corneal refractive index. The ability of the ray tracing software to be performed over a corneal diameter, minimizing potential instruments and thereby radius error. Finally, formula error are avoided as the IOL position may be calculated without respect to the single anterior curvature value. The result obtained by Savini and co-authors in recent paper further highlight the potential of the using value based on ray tracing principles. Hofmann suggests that although the prediction accuracy of ray tracing remain only comparable to third-generation formula, the accuracy in abnormal eye, those with a long or short, as Raina said, axial length, and those with the prior refractive surgery is improved. And that's the principle of ray trace. I will not go through. OCT-based IOL calculation also shows a promising to used in modifying the K reading and give us the actual K of the post-op result. Now, if we will go to the practical information that we are using is the IOL power calculation in the eye with ASCRS, and these are the form that they are using prior to myopia, where there is certain modification, and prior to hyperopia, the other modification, and prior to RK radial keratotomy. Although the number of formula may now provide an improved refractive outcome in post-laser refractive surgery patients, it remains difficult and time-consuming action to derive the IOL power using multiple formula. This task, however, has been made significantly easier with the advantage of several available website or app-based program developed with the support of ASCRS and ASCRS post-refractive calculation, ASCRS post-refractive calculator. That's the website of it. Remain an efficient method for obtaining multiple IOL formula. The program utilizes several references, formulas, and provide an average of all available methods. I have 7 minutes. Now, this is the formula, the page with the formula, with the information data that we need to admitted to. And one of issues that I'm using is that the net corneal power apex for 4 millimeter in myop, and it's only in myop, not in the hyperop. I'm using the average IOL power, targeting definitely considering the Barrett True K as in my consideration, but the average IOL power with the need of the patient, targeting myopic side more than hyperopic side. And I have patient with a plus minus 0.5 in considering those information submitted in this formula. And we are trying to get the more information. The more information that we are putting in these formula or these pages, the better result that we are getting. Now, one study, post-hyperopic refractive surgery, shows a conclusion, shows that the IOL predicted power calculation using Holiday 2 formula, LensStar, and ASCRS post-refractive comparison between Holiday 2 formula and ASCRS post-refractive IOL calculator for eye with a prior hyperopic laser, LASIK or PRK, was performed and compared to the actual manifest refractive spherical equivalent following cataract surgery. No pre-LASIK PRK information was used in any of these calculations. As consequence, we only obtained result from Shammas, Haggis L, and Barrett True K, no history online formula. And in the conclusion of this study, an eye with previous hyperopic LASIK PRK and no more data, there were no significant difference in the accuracy of IOL power calculation between Holiday 2 formula and ASCRS post-refractive IOL calculator. I have 5 minutes. And post-myopic refractive surgery with a study showing compare the accuracy of intraocular lens power calculation formula after laser refractive surgery in myopic eye. They conclude the Esker's average or Barrett true K, no history should be used to calculate the intraocular lens power in eye after myopic laser refractive surgery. The OCT formula, if available, can also be a good alternative choices. So Esker's average or Barrett true K with no history shows the high accuracy in comparison. With the conclusion, the Barrett true K formula can predict IOL power in eye that have previously undergone myopic corneal refractive surgery better than the Haggis L formula that's in other study. Conclusion, there are many methods of calculating intraocular lens power after keratorefractive surgery, indicating that there is no single accurate measure that can be reliable to perform this task. The use of mean of combination of formula yield excellent result better than any single formula alone for post-LASIK eye. Thank you. So that's my reference, and I will stop sharing just to allow my dearest friend, Nancy. Hi, Nancy. How are you? I think that you are mute. Okay. Yes. Now you are non-mute. Yeah, and I think just I need to ask: is there any question, Dr. Mohammed Amri? He's with us now. Maybe we are late. That's why he came to just to show us that we are late. Anyone? Dr. Nancy, we are welcome you. Yes, please.
So what's your thoughts, or have you utilized the Barrett True K with TK from the IOL Master 700 in the post-refractive eyes? Do you have experience with that? Because we've had good results and the studies show that it's great too.
Yeah, the Barrett True K in IOL Master 700. And
the TK, utilizing the total corneal power, the TK.
Total corneal power. So first, total corneal power, we are not using it for post-refractive formula, the net corneal power.
Mm-hmm. So the TK that the IOL Master 700 utilizes, they've shown a recent study actually that it's it does excellent and compared to also utilizing the Haggis TK. So if you get the refractive suite with the IOL Master 700, we've gotten good results with these post-refractive eyes.
That's right. You are right. Just let me highlight one thing. In IOL Master 700, it's used the net corneal power, which is mathematically raised, unfortunately, and the total corneal power, which is also mathematically depend on a very primitive OCT. And that's what we discover when we compare the whole result. So we are definitely, I don't have any financial disclosure here, unfortunately. But anyway, the net corneal power that we are using in post-refractive is different in its, because there is a lot of optical explanation differ between net corneal power and total corneal power. And the only use for the total corneal power, we are using it in toricity. So I don't think so that using total corneal power in any formula for IOL calculation gives you a good result. Anyway, I think that we need to go through and ask our colleague, Dr. Nancy, to start biometry postcorneal transplantation. Great, thanks, Dr. Zainab.
Yeah, thank you, Dr. Safwan, and thank you, Dr. Mohammed Amri, for inviting me to participate in this successful and impressive meeting. Let me talk about biometry and IOL calculation post-corneal transplant. So formation of cataracts can be accelerated after corneal transplantation and may require early cataract surgery. Why? Because of intraoperative manipulation during surgery, the use of air tamponade in certain procedures, there might be multiple surgeries done on the eye, or the post-operative long-term of steroid use. We have to highlight that to indicate what kind of transplant the eye got, whether it's a penetrating keratoplasty, a deep anterior lamellar, an automated or anterior lamellar therapeutic keratoplasty, or and endothelial keratoplasty. And it's important also to highlight where do we stand. So are we dealing with cataract in a transplanted eye, or is it a phakic eye that has to be grafted? Is my graft a DALC, a PK, a DSEC, an ultra-thin DSEC, or a DMEC? And how long has it been grafted? Are there sutures or not? And what's the age of the candidate? So what concerns we have? Planning for the appropriate IOL power to be implanted, the appropriate viscoelastic to be used, maintaining the endothelial integrity. Intraoperative visualization is an issue. Loss of epithelial integrity, strength of the graft host junction, postoperative increased risk of rejection of the corneal transplant, combating preoperative astigmatism brought by the corneal sutures, and inducing also astigmatism during surgery, and thus changing the corneal biomechanics. What if there's corneal dysfunction? Now, phakic patients with clinically significant cataract and endothelial dysfunction are better managed with performing simultaneous cataract surgery with the endothelial keratoplasty, whether it's a DSEC or a DMEC. In pediatric patients, combined surgery, we avoid it because we have to preserve the accommodation. Cataract surgery in eyes that had undergone DSEC previously is of concern, as this may affect the graft adversely and threaten graft survival. So it's important if you want to plan for cataract or IOL power calculation in DSEC patients or in a corneal decompensation, to do it simultaneously at the same time, or if you are waiting for a graft, to do it at 2 steps. So you do the cataract first, and then you transplant the endothelial graft. So what about IOL power calculation post-PKP? It solely depends on effective reading of the K. So Ks are essentially variable, and we have to aim at regularizing and stabilizing the corneal surface before attempting any surgery. We can add, remove, or adjust sutures until the corneal surface is regular and stable. And once we take the measurements, we have to address any surface issue like dryness, and then we can use the biometry using the regular formulas. Slightly aim for myopia, because if we do it early, sometimes the cornea, especially if the patient was a keratoconus and transplanted and you have over-flattened the cornea, it will shift into some hypermetropia. So I am slightly into myopia as it progresses or the sutures are removed, then to adjust for the change in refraction. Now, for me, removal of all sutures is not a must after PKP surgery, especially in the young. So I don't have to remove all sutures if the patient is young and I want to do a cataract surgery for him, because my priority is stabilizing the cornea, and part of stabilizing plan is putting stitches in the cornea. What if it is irregular, even after transplantation, or is it has been transplanted long time ago, and you cannot just regularize it the common way? This is not an easy decision, and the principle of management is, although the principle is simple, it's not easy to apply. So basically, we have to eliminate and reduce the corneal irregularity by addressing the source of the problem. Either medical, if it's a dry eye, we have to treat it. If there's a Salzmann degeneration, if there's an overgrowth, vascular overgrowth or vascularization, you have to try to optimize the surface as much as we can, surgically or medically. Take repeated measurements, because this affects the case at the end. And this is when I consider the EKR 65, which is the EKR 4.5 zone on the holiday report, which is the best predictor of the corneal power whenever the pupil is normal of size. And if the pupil is small in size, between 3 and I take the 3 and 4 millimeter zone on the EKR 65 holiday report and use it in any regular formula. So the newer generation we use on irregular corneas, the better predictor it is. And the more measurements we take, the better results we achieve. Now, what if it's already cataractus and we want to perform PKP? And although I do this a lot of times, but it's generally better to avoid triple procedure, because there's no single method can be used accurately to carry out IOL power calculation prior to corneal transplant, combined with cataract removal and intraocular lens implantation, simply because the cornea and the face of the eye will change, and you cannot rely on something that will become history. So if a lens is to be inserted and you have to insert it for a reason or another, At the time of the transplantation, you either use the average case and you take 43 or 44 diopters to get the least refractive surprise, or use the central corneal power, which I think Dr. Zeina was asking about just shortly. And of operating on a keratoconus eye, I usually tend to overcorrect or choose an IOL power that is more incised with 3 to 4 diopters to overcome the flattening effect I'm going to do with my PK. But definitely have to tell the patient about the refractive surprise and the need for maybe a touch-up or a tweak after the procedure. Now, the preferred approach is this. You wait for 4 to 8 months. When the corneal curvature has stabilized and the corneal astigmatism has been minimized, you do an aphakic refraction with simulated keratometry by topography to estimate the central corneal power. And then you place the lens, you go in another procedure, you place the lens in the bag, if it's open, or the ciliary sulcus, and usually arrange for a 3-piece IOL. Now, this approach is based on the aphakic refraction and the vertex distance and the lens position and corneal power. It is axial length independent, which minimizes the error in this kind of calculation. And because we are learners by example, I'm just going to show you how different the approaches would be if we adopt a specific technique in dealing with these patients. Now, I had this patient who was a 41-year-old male patient with keratoconus. The right eye was transplanted, and he was pseudophakic with a refractive surprise, and the left eye showed infective keratitis that showed to be acanthamoeba. And it took me 9 months to treat him, and then the eye went into scarring, and then it was the time for visual rehabilitation. So I planned for a PKP, and I had concerns about when to do the PKP because of the high dose of steroids and all the dilemma that goes with this decision. And he had a white cataract behind it. So the question was, would I remove the cataract at that time of the PKP, or would I risk repeating the refractive surprise in his right eye and deal with it later? And if not, which formula and which IOL or in which lens side? And would I keep the lens in the antiphacolator, giving no improvement in his vision with PKP alone and endangering his graft with a difficult phaco later on? All these things, they just brew in your mind whenever you deal with a patient that needs both refractive elements in his eye, the cornea and the lens exchanged. So meanwhile, I just wanted to check what the results I would have from the IOL master. And so the SRKT gave me minus 0.5 diopters of the, this is before transplantation. The Holiday gave me a 1. Let me see, the Hages gave me a 7. The SRK2 gave me 7. The Holiday gave me 1. And the SRK2 gave me a 0.5, and I got a planner. So if you want to confuse yourself, do this and get many IOL masters and biometries, and then try to pick one of them. So this is not the preferable way of doing it. So the decision was to do a PKP and an open sky STCE, because definitely you wouldn't want to mess with the cornea that is inconsistent and that would change, that will become history. And I just want to emphasize on something that Dr. Assaf has mentioned before, that biometry in keratochronic eyes usually underestimates the IOL power and overestimates the corneal power. So we have to incline on a post-operative hyperopia. So what I've done, PKP, open sky, left aphakic, I left a viscoelastic in the capsule as a desperate measure to find it later on open. I made sure to make my sutures as regular as possible. And if you can see, the lower photo is the pre-transplanted eye, and the upper one is the post-transplant eye. And as you can see, I worked on the surface from a very irregular cornea into a very regular bow tie cornea. And then we monitored this patient regularly to avoid any change in his post-operative refraction. And as you can see, there was minimal astigmatism. The hypermetropia was due to his aphakia. Later on, I repeated the refraction, which is 3 or 4 months later. And as you can see, because it is somehow irregular, the consistency between the Holiday, the SRKT, and the Barrett IOL power And so with much comfort, I could choose one of the lenses and insert it. And luckily, I found the bag open, and I could go on and then correct his astigmatism later on. So what about DOLC? DOLC, you treat it as the same as PKP. Definitely, you don't do cataract surgery at the same time, but you do it later on. And you have first to optimize the surface before attempting a cataract removal. The thing about deep anterior lamellar that's different from PK is that you don't have to wait a lot for the sutures to be manipulated or removed. What about endothelial keratoplasty, DSEC and DMEC? Now with DSEC, the change in the postoperative sphere equivalent of manifest refraction is between plus 0.6 and 1 and 0.26. Now, as I said, it's better to do either a combo, which is a DSEC phaco at the same time, or do the phaco first and then aim for a DSEC, not the other way around. And because there would be a postoperative hyperopic shift, so usually it's better to compensate for that. By three methods. You can select an IOL power by predicted refraction that is around -1 diopters, because usually the myopia lies between -0.5 and -1.5, according to a study by Covet et al. Or you can adjust your K readings using the IOL calculation formula, or optimize the constant for the IOL. What about DMEC? Although we know that DMEC is around 14 to 20 microns, and it contains only donor decimus membrane in the epithelium, but it does usually induce slight changes in the corneal power, which is around +1 diopters hyperopia, and this is attributed to the deswelling of the posterior stroma and steepening of the posterior corneal curvature, which compensates with a hyperopic effect. So usually you should aim at a -0.75 diopter lens. And yeah, I just want to end this and with this slide, and thank you very much for listening to me.
Great, thanks, Dr. Nancy. I think that it was a very nice, interesting, but still there is a few things that we need to mention, that still we are facing a hyperopic shift with after the corneal graft. So you agree with us that the best issues is to target the myopia according to the K reading that appear after the KP. But sometimes we are facing a very flat cornea. So in this situation, because the dividing the penetrating keratoplasty to what you said, that's right. It sometimes it play a role, but if you'll divide the issues on a flat and steep cornea, so is there any adjustment for a very flat? So what's your adjustment for a very flat cornea?
Yeah, we can also divide it into a recently transplanted cornea that I can play with, or a cornea that's transplanted long time ago, and it's most likely that I wouldn't be able to do a lot about that.
Yeah.
So if it's a recently transplanted cornea, it's very easy. A flat cornea can be domed by playing with the stitches. So if your stitches are, you can do selective stitch removal or exchange, so that the type of stitches that you place, they can just dome the cornea more, giving it a little bit of a doming and a little bit of a myopic shift. And this is really very reproducible. And these are the kind of patients I like to manipulate with. The kind of patients that I don't like to do to mess with are patients who have like their grafts done 15 years ago, no stitches at all, and the cornea is either very myopic or very hypermetropic. And at that time, at that instance, I do sometimes selective stitch revision. I do revision of the wound and placement of the stitch. So if it's a myopic, I would depress it. And if it's a hyperopic cornea, and depends on the degree of the of refractive error, if it's a hyperopic cornea, I would dome it. The cornea is a very forgiving tissue, and doing this just give us great results.
Mm-hmm. Great, thanks for all. I think that Hamad Al-Amri, he's with us. I think that if he will be unmute, he will say something with the. But this is not a last session, right, Hamad? Unmute yourself.
Good evening to all. Thank you, Safwan. No, this is not the last. We are having
not the last. Still, we have more sessions till now.
I
And
get you.
so, Muhammad, you need to keep us in I'm in the clinic, Muhammad. I'm in my center till now. It's now 10 p.m. in Dubai. I don't know what's the time in Amman. Amman, I think that it's now 2 hours, 8 o'clock, right?
We're 2 hours ahead.
Yeah,
you're 2 hours ahead. So
in Egypt also ahead. Yeah. And Egypt also 2 hours. 2 hours ahead. So at least 8 o'clock. Yeah, but I'm يعني, I don't care. My wife, she washed her hands from my side. That's all finished. So there's no hope from myself.
Dr. Safwan, happy Valentine, by the way.
Happy Valentine, yeah. That's the happy Valentine that I will return back to her. I will say that Muhammad, he made a prisoner there.
No, I will tell you the truth, Safwan. I give you a good chance to say away. That's you are playing with. Yeah, I know. What are you doing?
Very good. Okay, anyway, so we need to finish this session. Is there any
very
question?
much. Thanks a lot.
Is there any question from the panel? It was a very pleasure for me to join this panel. This is a great panel with this great information that I learned a lot from it. And hopefully that we will meet later on physically and we will see you together in another sessions. And we need to say goodbye.
Thanks for the opportunity.
Thank you.
Thank you, everyone.
Happy Valentine for all.
Valentine for all. Happy Valentine.